Hello everyone, and welcome to the 20th Annual Scottsdale Interventional Forum and this edition of the procedure. I'm Michael Garrett, Associate Vice President at HonorHealth. This year's scientific session is distinguished by a few important particulars. First, we're back in full force. The pandemic's worst is behind us. There are no holds barred. Second, Dr. Rizik and his team received an honor accorded few in medicine. This distinguished group received an Emmy Award for its production, The Procedure. Through the procedure, many in the AZTV viewing area are able to experience firsthand the life and death drama associated with the diagnosis and management of heart and vascular disease. We at HonorHealth thank Drs. David Rizik, James Hermiller, Mark Reisman, and the entire faculty, staff, and planners for this wonderful edition of the 2022 Scottsdale Interventional Forum. We hope that you will enjoy today's production of the procedure.
This time on the procedure. We are all born with a hole in our heart. While necessary during the developing stages in the womb, this hole between the upper chambers becomes unneeded after birth. For most, the hole closes, but for roughly 25% of the population, it never does. Most of these people never know they live with this hole, called a PFO. No symptoms, no medical problems. Yet for an unfortunate population, a PFO can mean life-threatening and debilitating events. If a blood clot forms and finds its way through this hole, it can lead to a stroke and even death. In the past, treatment for PFOs involved invasive open heart surgery, but today, thanks to medical advancements and utter perseverance, these holes can be closed from within using a catheter-based device called an Amplatzer PFO Occluder. Join us as we take you live into the cath lab to see one of these procedures firsthand. See the technology, meet the pioneers, and see the lives that are touched with this groundbreaking technology. The procedure is made possible by educational grants from Abbott Laboratories and Siemens Healthineers.
And welcome to the Emmy-award-winning procedure. Dr. Rizik here with me. I am Brad Perry, your host, and I'll tell you, Doctor, we have been in this operating room 3 times. This is our 4th. And this one is a very different one that we've been through. And let's explain a little bit to our viewers out there how this one plays to younger people and also healthier people compared to the ones we've done that were disease hearts.
I think that's an excellent point. Most of what we have seen so far, coronary disease and whatnot, are acquired diseases, diseases that maybe through lifestyle or living, people acquire this disease. What we're going to do today is close a hole in the heart. That's not an acquired disease. That's something that patients are born with. We call this a patent foraminal or PFO, and this has nothing to do with lifestyle, but rather patients are born with this. We call those congenital abnormalities, and it's only when something happens later on, like a stroke, that this hole in the heart is discovered.
Again, after sitting and talking with you about this, it's amazing how many people go unrecognized with this after having a minor stroke. And that's why this procedure is so important to talk to people out there. We'll talk about the different ways they need to address this with their doctors and everyone. So, but if this is your first time with us here, let's just talk about what we're going to see in here before we meet the doctor's lectures. So what we'll do is we'll be showing off, of course, a few of the heart monitors and different things going on. But the big part is that I had the opportunity to go into your office and work on a model. So let's take a look.
Yeah.
Okay, Doc, we are here doing a little demonstration for me. And again, this procedure is very important to younger people.
This is different than some of the other procedures that we have discussed. Most of what we have discussed are acquired diseases, maybe through lifestyle, maybe through aging. People develop coronary disease and valvular heart disease. This hole in the heart, or what we call a PFO, patent foramen ovale, this is something you're born with. This is what we call a congenital abnormality. Wow. Bob, maybe you could describe a little bit about how a PFO develops and what exactly it is.
So yeah, the PFO is required equipment. You can't get out of the womb without one. So before you're born, all oxygen comes from mom and it goes through your belly button. Goes up to the heart, and then it goes to the right atrium that Dr. Rizik had already described, and crosses over through this foramen ovale to get to the left side so that you can get oxygen to your body and develop, and that's normal. Now for most people, that's going to close within the first several months of life. What happens is that it just shuts down because there's higher pressure on the left side than the right, and it closes it, sort of closes that door, and then you heal. It's just like a scar. Unfortunately for 25% of the population, it doesn't completely close. And that allows a persistent possible passage, this little flap that goes from the right side to the left, that would allow for clots to potentially go from your legs or your arms into the circulation and then potentially go to your brain and cause a stroke.
Wow. Amazing. Okay, we have the model here, which is very interesting because, you know, when people see the heart, when we show it, it doesn't look like this, and this is better to explain to them what's going to happen.
That's right. This is an acrylic model, which actually shows this abnormality we're talking about. These are the upper chambers of the heart, the right atrium and the left atrium, and the lower chambers of the heart, the pumping chambers of the heart, the right ventricle and the left ventricle. Now on Valentine's Day, you know, you see the heart look like this. It doesn't exactly look like that, but this is close enough. So the hole is between the two upper chambers of the heart, between the right and left atrium. And as Dr. Burke was explaining, a clot or other debris can come up from the leg and cross over from the right side to the left side. And once it's on the left side, now it's in what we call the systemic circulation, and then it can travel to the brain and cause a stroke. So this model very nicely shows this communication, if you will, between the upper chambers that allows for the stroke to occur.
All right. Okay, I know this is the model, doctor, but that's not how big the hole is it?
Not at all. And it's not actually a hole like this shows. This is good for showing an audience. It's more of a flap. It's a communication. We say it's like a woodchuck burrow. It's a long canal or a flap. And what usually happens is this flap closes over time, but in 20 or 25% of the people it doesn't close. Now this is a beautiful model for really demonstrating how we close it.
So, all right, let's take a look at closing this, because it's going to be very interesting what we're going to see in the operating room.
All right, so we have a catheter that comes up from the leg, and the catheter crosses the hole. Actually, you're going to close it. You're going to do your first PFO closure.
Oh my goodness. All right.
Okay, so in the procedure that we're going to see, the catheter comes up from the leg, crosses the hole. Now I'm going to hold the catheter in place. What you're going to do, there are two discs on this closure device. The left-sided disc that you're going to deploy is about 18 millimeters. The right-sided disc is 25 millimeters. To deploy the left-sided disc, put your right hand closer to the left now, okay. And to deploy the left-sided disc, simply push. Push slowly. Now you've just deployed the left-sided disc. Push in just a little bit more. Stop right there. And then we pull the catheter back against this wall. This wall is called the septum. Now to deploy the right-sided disc, you're going to move your hand back this way, and you're going to pull your left hand toward your right hand. Pull the left hand toward the right hand. Go ahead. Good. Now push it in, and there, you've just closed your first PFO. You're a real pro at this.
This is amazing to see this.
So you've deployed this. Now it looks a little bit loose, but we've used this model several times. But in a human being, when we put this in, it actually purse strings very tight on this communication, on the septum there. And now it will never let a clot pass across that opening again.
Wow.
Now the next thing you want to do is you want to disconnect it.
Okay.
So we're going to pull this back. Now to disconnect it, it's very easy.
Okay.
We're just going to unscrew it like this, unscrew it, turn it to the left or counterclockwise, and there it is.
Oh, wow.
You've just successfully done this.
Wow, that's amazing.
You've just closed your first PFO, Dr. Brad.
Okay, who's the surgery benefit and how does it help them?
Unlike elderly people who may have a stroke because they have blood vessel disease of the brain, this occurs in young people. In fact, I want to share a story with you about a young woman who had blood vessel disease or vein disease of the lower extremity, developed a clot, a very healthy woman, worked out all the time, the mother of several children. I mean, this was a very, very healthy, active woman, and yet she developed one of these blood clots that crossed a PFO and it caused a stroke.
Oh, let's take a look.
Kids, we'll get dressed for school.
You in my neck.
Doctors. Hi, my name is Danielle. I'm 37 years old and a mom of 4 wonderful children. I'm an avid runner and live in beautiful Scottsdale, Arizona.
Boys, you want to go?
We have a very crazy schedule with sports with them. We are coming and going all the time between volleyball, baseball, football, you name it.
Say bye to mom, hugs and kisses, let's go, say bye.
I never thought something like this would happen to me. I was walking my kids out the door for school. My husband was taking them to school and felt, as I watched them walk away, I locked the door and I just felt this crazy rush go up my arm. It's really weird and I kind of leaned against the wall, but then as I did that, my head started like, whew, and so I was like, oh my gosh, something's happening. So I was able to unlock the door and get out front, but as I walk out front, my husband's literally pulling away from me in the driveway. So I went to go yell for him, and that's when I was like, oh my gosh, I know what I'm gonna say, but I can't articulate a word. It's like, it was the only sound I could make. So then I started really panicking. I was like, I'm thinking I'm having a stroke.
My father died from a stroke, and so I'm really familiar with the signs of things like this happen, unfortunately. And so I was sitting in the driver's seat, and then I just see her.
Bailey started yelling.
Yeah, Bailey kind of, Mom.
She's fine.
She was like, look at Mom. And I kind of looked at Danielle, and she was coming out the front door, and kind of looked weird. I don't know, I've described this a couple times. It's like you're talking through your eyes, but you can't say anything. I could see that she was really struggling.
A PFO is a hole in the heart. That hole in the heart is necessary during your development in your mother's womb. However, once you are born and you start breathing on your own, a flap closes that opening. It was very clear that when you saw the ultrasound that there was a hole in the heart, and very likely that's where the clot had come from. This was just such a young, energetic, athletic woman, mother of several children, who recently had a baby, and really the thing that predisposed her to having a stroke was that she had chronic inflammation of the veins in her legs, a disorder called thrombophlebitis.
The fact that these things happened to her, I think, were a little bit,
Shocking.
yeah, a little bit shocking to us.
I was like, I don't want to get this done. Like, I don't want to. I'm fine. And like Dr. Isaac said, he's like, no. Once you have one, you're prone to more. And with age and with time, each one becomes worse. I remember being in his office, like crying and being like, I do not want anybody touching my heart. Like, I've lived my whole life without this. I've lived a fine life. I've had 4 healthy pregnancies. I run, like, I don't want it done. And he left the room. His daughter was there visiting, and he came back into the room with his brand new grandchild.
With his kids,
and put the grandchild on my lap, and he's like, this is why you need to do it. And I was like,
It was the perfect
it was.
it was like a teachable moment. Like, here, this is why we're doing this.
We began talking to her about performing a heart procedure. And if you begin to research it, you see that just a few years ago, this was an open heart surgery to have a PFO closed. So we sat down with her and her family and discussed at great length that this was a minimally invasive, catheter-based, non-surgical procedure, and that we could probably do this on a Friday, and by Saturday morning should be ready to go home. The procedure went so smoothly. It was a picture-perfect closure, and we were all very pleased and very confident that that she would never have this problem again.
Nobody should fear the procedure. It was so simple. It's amazing that they could fish this little like rolled up tube and open it up in your heart. It's just amazing. I was in the hospital, I think, only for a night, and then I was able to go home and I'm back to myself. And I'm better, and now I'm safe. I feel good now. I think I was touch and go for like that year after, like, oh gosh, did I feel something, or is it in my head? Or, you kind of second guess any little like weird cramp in your chest or something that happens, like, oh my gosh. But I'm so far past that now. I could run at high levels, I could race, I could do stuff that makes my heart rate get excelled, and I don't have any issues. I feel fine, and I feel back to myself mentally and physically.
I think the underlying message, I think, is that this can go away in a heartbeat. That this life, this experience we're going through together, that's so amazing, can end in a moment. That for me was kind of the scariest part of all this. She's my best friend, she's my rock, she's everything in this world to me. And so seeing that happen to her, you almost wish it happened to you. And so to have it happen to your best friend, the love of your life, the mother of your children, it's kind of one of those moments where it rocks you to the core.
Go get a bubble test if you have any like procedures or anything simple. It's the simplest. For me, I lived my whole life not knowing I had this, and my situation was really unfortunate with kind of the perfect storm. I had varicose vein surgery, that clot breaking off, having the hole in the heart, passing through my chamber and going up to my brain. It was just kind of the perfect storm. But I feel like had I known that I had that before the vein surgery, I don't know.
25% of kids have this.
Part of a physical or something.
It should be kind of part of that physical you do for every sport.
It is like the simplest test that could honestly save your life. I feel like had I not gone in to get my varicose veins removed, I often wonder, like, would I have found out? Like, when would I have found out? Where would I have been? I feel like especially for women that are of childbearing age that do, because varicose veins are such a huge issue, and so many people have them removed. Literally takes 5 minutes to have this test done. It's painless, and just make sure. I mean, I think it could honestly could save your life.
Wow, doctor, that story, it's kind of mind-blowing, because when we think of, people who are going to have heart surgeries or different things, we're thinking older. Right. We're not thinking, in the 40s, or we're thinking more going towards 50 like me, or even above. And this is kind of interesting to see this. And that story was just, wow. I mean, I'm still goosebumps.
As fascinating as the story is, and the technology and whatnot that in all of the things that she went through, I think equally fascinating is the background on the device, on how it was approved by the FDA and how it almost wasn't approved by the FDA because there was difficulty in showing benefit. And it's such a life-saving device, but there was actually difficulty in the studies. We call it the device that almost wasn't. Wow. And we have someone who was irrevocably linked to the studies. He's, to me, a genius, and his name is Bill Little. Bill's coming to us by Zoom. Bill?
Bill, hi, how are you?
Hi, good, Dr. Rizik. Hi, Brad. Genius is probably an overstatement, but thanks for the compliment.
Tell us about some of the little bit of a rough ride that you had getting this through FDA approval so that we could use it in patients.
Yeah, well, rough ride might be an understatement. It was was quite a challenging time for us. And it really goes back to the beginning of this device and trying to prove that benefit for patients. As you know, almost 25% of people walking around everywhere in the United States, all around the world, have this hole between the upper chambers of the heart. We call it a PFO, and that's an acronym for a patent foramen ovale. And what that really means is that there's a hole between the two upper chambers, or the two atria of your heart. And in most patients, when you're born, shortly after you're born, that hole naturally closes up. But in some patients, that hole stays open. And for most of us, that's fine and it doesn't cause a problem. But what clinicians and what doctors started to believe a long time ago was that maybe some of these patients that are having strokes for no good reason, maybe it's because maybe a tiny blood clot is passing between that hole in the heart, or maybe it's forming in that heart and ending up in the brain and causing that stroke. And so that became the theory behind this device. And the idea was, well, if we close up these holes, then the blood clot can't transfer from one side of the heart to the other, and therefore those patients would have fewer strokes. And it seemed like a great idea, and so the company decided, well, let's go study this in a clinical trial. And they started this clinical trial in 2003. And the idea was that they were going to take about 1,000 patients, and they were going to give half of them a device, and the other half of them, they were just going to treat as you normally would with standard of care medicines.
So we call that a randomized controlled trial, and that's how most devices are, that's the studies that we do on most devices, and then we take that data, that science, to the FDA, right? In other words, half the patients get the device, half just get regular medical therapy, and then we compare the two arms, and the FDA helps to drive the decision to approve it for human use.
That's exactly right. And I think the most important point is all of these patients had already had a stroke. So you can imagine a 46-year-old patient, and that was the average age of the patients in this trial, and most of them were women. So I'm a little bit older than that, and you can imagine a 46-year-old woman who might have a couple of young kids who has a devastating stroke. And it's really life-altering for these patients, and it's a tremendous burden for them to carry. And so this idea that there could be a method whereby we could implant a device and prevent a future stroke was really appealing to patients.
Wow. So we got to the point where the trial was completed, and you said 500 patients about in each arm?
Even before we got completed, though, there was a little bit of trouble along the way. So as we started to enroll these patients, and we'd have a patient that had a stroke, and then we would put them into the trial, and half would get the device and half would not. Well, in the background, there was another device available that physicians could use, and it wasn't yet approved by the FDA, but physicians on their own accord could implant it into patients. And so what happened to many of these patients that, to use your term, that were randomized into the group of patients that weren't going to get a device, well, you can imagine you're a 46-year-old woman and you've had a stroke and you decide to go into this trial, and then they tell you, I'm sorry to tell you, you're not going to get this new device that might prevent your stroke. You just have to wait and see. Well, a lot of those patients decided that they were going to go take a chance with another physician and close that hole between the chambers of their heart with the device that wasn't approved. And so what happened was that only happened in the group, or I should say it more commonly happened in the group that didn't have their hole closed. And so what that led to is we really didn't have a fair test.
We still hadn't proven that this works, that this is the right therapy, yet they were seeking other forms of care.
That's right, and we didn't plan for that. So in the trial design, it didn't account for the fact that these patients were going to go get their PFO closed by some alternate method. So then we'll fast forward. We finally enroll all these patients. It takes about 10 years to get this done.
Wait a minute, 10 years. You've got the patience of Job. 10 years to finish an enrollment. Oh my goodness. I can't imagine how eager you were to get this done, but 10 years?
Yeah, so 10 years. And interestingly, the way we decided we were going to complete the trial is we were going to watch how many patients had a second stroke. And we didn't know which group they were in, but when we initially designed the trial, we said we're going to put 1,000 patients, about 1,000 patients in. And when we get to 25 strokes combined, Then we're going to look and say, which arm were these 2 patients in? And let's say 20 of them happened in one group and 5 happened in the other group. Well, then we would know that there was, for example, a difference between these 2 treatments and that it worked. And so we get to the 25 strokes. We finally reach this after about 10 years, and then we go to look at the results. And none of us had seen what those results were at this point. And so that's when it also gets quite interesting.
And let me set the stage. The data is about to be presented at the biggest international cardiology meeting taking place in Florida, if I remember right, because I was sitting across the hall from you when the data was about to be reviewed. What happened? What did you see?
Well, it's interesting. And just prior to that, about 4 months prior to that, the CEO of the company had gone out and told the analysts, the Wall Street analysts, that we've seen the data and we think they're going to look very good. So there was high expectations, not only in the physician community, but also in the financial and in the investor community, that we had this breakthrough treatment that was going to be able to treat this huge number of patients and really was going to be a blockbuster device for this medical device company. So that was all part of the background. And so we get in there, we look at the count, and the count between the 2 groups was 16 strokes in the arm that had no device and 9 strokes in the arm that actually got the device. And remember, patients can have strokes for a whole bunch of reasons, not just because of a PFO. And so that difference basically didn't reach what we call statistical significance, meaning that the statistician looked at it and said, hey, there's still a chance that these differences between the 2 arms are due to random chance and not, in fact, because the device worked better than the drugs.
So it wasn't an impressive enough of a difference between 9 and 16 strokes device and not receiving a device for someone to say, okay, good, this is a device that works. It just wasn't a substantial enough a number.
It wasn't in the purest statistical view. But as part of this trial, we looked at a lot of different ways of analyzing these patients. And remember, I told you that 16 in one arm had it and 9 in the other arm. Well, the way we counted those strokes was the minute you were into the trial, and we said, okay, we're going to pick which side you're on. You're going to get a device, you're not going to get a device. From that point on, anything that happened to that patient was an outcome of the trial. And that seems like the right way to do it. It's certainly the gold standard, but there were a couple of things that happened along the way that really presented problems. For example, one patient got randomized to get the device, and she changed her mind. And she said, you know what, I don't think I want to get this surgery. Later on, she went on to have a stroke. She never got the device, but because of the design of the trial, that counted as a stroke in the device group.
But she never received the device.
She never received it. Wow. We had another patient that was randomized to get the device. Her surgery was scheduled for a week or 10 days later. A few days after she was randomized, but before she got the device, she had another stroke. That counted as a stroke against the device. We had another patient that was randomized to get the device, had some chest pain, ended up having to go in for a bypass surgery. During the bypass surgery, completely unrelated to her PFO, she has a stroke related to the bypass surgery. That counts as a stroke against the device. And so we had all of these anomalous things that are part of the real world, but didn't actually reflect how well the device worked. And so when we looked at when we actually had the device in place and patients that got the device versus not getting the device, what did those numbers look like? And in that case, it was crystal clear, over 99% likely that the device itself was effective in preventing strokes. And so that's what gave us so much hope that we really had something here despite the initial findings of the clinical trial.
So the trial took 10 years to do, and then you had to go through all of these statistical analyses. How many years after the trial was done did the light bulb go off and we said, all right, there is a difference? How many more years did it take?
Yeah, well, that's an interesting story. The short answer is it took about another 4 years. And in the interim there, we almost stopped the trial. And there were 2 camps within the company. One group of folks said, hey, we've already spent tens of millions of dollars in 10 years, and we should just cut our losses and move on. And another group said, no, this is real, and we have to keep following these patients because remember, these patients are at a risk for stroke for the rest of their lives. And if we keep following these patients, there's going to be more strokes when the patients don't have the device than with the patients that do have the device. And ultimately, the group that said, let's keep following these patients and invest more money in the trial, ultimately that group won. So we fast forward 4 years later, and now we've had more strokes in both arms, but of course, the group that had the device had fewer strokes than the group that didn't have the device. And this time when we looked, it did hit that magical statistical significance, and we were able to take it to the FDA and finally get the device approved.
You took it to the FDA 14 years after the trial began. And that's why I always call this the device that almost wasn't, the technology that almost wasn't. It took 14 years. And think in that time frame, how many more people had strokes?
Wow.
Yeah, and so one thing to think about here, Dr. Rizik, is remember that the difference between these groups was about 1% per year. Now think about that if you're 46 years old and you've got a 1% chance of having a stroke every year for the rest of your life. Let's say you live to be 86. That's a 40% difference over the rest of your life of having a stroke or not. And you can imagine living with that burden and thinking, geez, when is the day that I'm going to have my next stroke? I've already had one. Or I could go get this hole between my heart closed and dramatically reduce the risk of that stroke. And that's the promise of this therapy.
Bill, Dr. Rizik, this is so amazing that this has come about. And we're going to see one more story, and then we're going to head into the surgical room ourselves.
And do one for real. Thank you, Bill.
Thank you.
My name's Steve. I live here in Jackson Hole with my wife and 4 kids. Absolutely beautiful place. 56 years old, and while I'm not a triathlete or anything, I keep pretty active with all the things that are going on here: skiing, snowshoeing, a little bit of rock climbing with the kids. I never thought something like this was going to happen to me. Over the years, I had 1 or 2 headaches, migraine headaches, maybe once every other year. So when the symptoms kicked in for this event, that's what I thought it was at first. I was walking upstairs to go see a doctor. My vision went black on one side. I sat down and I couldn't form a sentence. And after a few moments, it was pretty clear to both of us that something was really wrong, and they called an ambulance.
He had experienced a stroke, and actually if you look at the MRI of his brain, the images of his brain, you can see that he probably had several strokes. It was more than one.
I remember getting the call that he was in the ambulance on the way to the emergency room at the moment of the 3rd stroke. And I had no idea how minor it would be, how major it would be. So yeah, that was a very scary day.
The question really was, what was causing this? I had an echo of my heart done, which showed that bubbles were passing through from one chamber to the other, and that indicated there was a hole there.
A PFO is basically a hole in the heart, and it's a hole that you need when you're developing in your mother's womb, but that hole is supposed to close, and in most cases does close shortly after birth. But about 20 or 25% of adults have a residual opening or a residual hole, and most people don't even know they have it.
When I understood that it was a small blood clot that had gone through this hole up into my brain and had shut down parts of it, it's just a little alarming to think that it could have happened in a bigger way and possibly caused permanent debilitation. I'm extremely grateful that a solution to this problem was found. The procedure that I learned about through some spiffy animations is the PFO closure, where rather than chopping you open in the middle and having to break ribs and put you back together, that takes weeks or months of recovery, they could just go in through my leg, place the Amplatzer device, I mean, it's still spooky to go right into the middle of the heart to do this procedure, but you know, I had it done, 6 days ago, and after a couple days of rest, I'm pretty much back to doing everything I did before.
Steve's prognosis is fantastic. Steve is going to have a great quality of life, a full life, and the chance of Steve ever having another one of these strokes again is extremely low.
I think the outlook's very positive because he won't have to be on a blood thinner, and that was problematic, especially if you live in Jackson Hole, Wyoming, where there's extreme skiing and extreme mountain biking, and we have 4 children, and Steve was recommended to not participate in any of those more risky but super fun sports that our children do.
Yeah, I'm so grateful that they developed the technology to be able to do this. I never thought I had something going on in my body that could lead to a permanent disability. I think what I talk about with friends of mine is that if they ever experience something where they feel like their brain has sort of slipped out of gear, to get it checked, to get it looked at, and the fact that I recovered so quickly, within an hour or two, it really makes me think that people need to pay attention to these kinds of symptoms. I had no idea that I had had 2 previous strokes, really, because I think the symptoms then had been so small. If I had been watching television, I would not even have noticed it at all.
When he came into our bedroom and said to me, "I just want to let you know, I think something happened, it was really weird," we should have gone to a doctor right then. We shouldn't have waited for that 3rd stroke, which happened gratefully in a medical setting. But we're so blessed, there's been no difference, gratefully. I don't think there was any lasting effect of that stroke.
Oddly enough, I think I had a cognitive test done that showed some scores went up. But now I have a built-in excuse for where I put the car keys and forgetting people's names. I'm so relieved. I'm so relieved to know that at least, you know, we never know what's going to happen in life, but to know that this is something that's probably not going to be a problem going forward. It was just great to know that I was in good hands to get this done.
Doctor, an amazing story.
Isn't that something?
This is just incredible. If you're just tuning in, you are watching a live heart procedure here on AZTV7, and it is the procedure show. This is our 4th one with Dr. Rizik and his team here at HonorHealth Shea. Let's introduce the room and who we have here.
That's great. Okay, so in addition to Brad Perry, who we always love having here, my partner for many years, someone that I just love doing these cases with, Dr. Mullick Shaw. Dr. Shaw is not only a superb clinician, he actually runs our entire division. Mullick, thank you for being here with us.
Thanks, David, for letting me join. Good morning, Brad. Good morning, David.
This gentleman back here is Dr. Kush Agarwal. This is actually one of Dr. Agarwal's patients that we're going to do this procedure on. Dr. Agarwal, you're going to tell us a little bit about this patient in a minute. We have an incredible team. We have Dr. Burke. You know Dr. Burke from previous procedures. He's an extraordinary imaging expert. He's going to show us some fantastic images. Dr. Garcia is our anesthesiologist, again, a real superstar. And then the staff in the room, we have Erin, who's going to give us some x-ray images. We have Megan, who's sort of circulating the room and running around. She's getting her steps in today. And then I want to introduce this young lady right here. She is fantastic in every way. Brittany does many of these cases with us. She does a superb job. She knows what we're going to do before we actually do it, so thank you, Brittany.
Yeah.
All right, let me orient the room, if you don't mind.
Yes, please.
The orientation of the room. This is the foot of the bed. This is the head of the bed. And if you look closely here, this is the access point into which we're going to place this device. It's non-surgical. We're not opening the chest. The device will go through this catheter, unlike if we were doing this procedure 20 years ago, which was an open heart surgical procedure. This is catheter-based, a minimally invasive, like keyhole in the leg.
Yeah.
And then we're going to get all kinds of nice images. We're going to deploy this with fluoro or x-ray images and ultrasound images that Dr. Burke is going to give us. And using both of those imaging modalities, x-ray and ultrasound, we're going to hopefully get a near perfect deployment of this device.
Yeah, and those at home, if you're trying to understand this, they're doing this all without opening the heart up like they used to crack open the chest and do, and it's really through sight with this team together, which is so important.
All right, now let me show you the device. Dr. Shaw, would you help me demonstrate the device?
Sure.
The device goes through this catheter. Dr. Shaw, explain what we have in terms of this device here.
Yeah, absolutely. So we're going to go ahead and plug in the hole that everyone's talking about, that PFO tunneled hole. And this is the device through which we'll close it. So one side of this device will sit on the right side of the heart, and the other side will sit on the left side of the heart. One side is about 18 millimeters in diameter. You can see the smaller side. And the other side is 25 millimeters in diameter.
So it's really like a clamshell. It's going to purse string over that hole.
That's a great description of it, exactly.
Okay. A little bit about the patient. Dr. Agarwal, maybe you could tell us, you made the diagnosis, you first met this patient. Tell us a little bit about him and what happened.
Thank you, Dr. Rizik. This is a young man, a father of 5, a very hardworking man. He presented with, unfortunately, a stroke last November before Thanksgiving. He had left arm weakness, difficulty speaking. Luckily, he presented within a few hours of symptoms to one of our sister hospitals and was treated emergently with IV clot buster medications. Thankfully, it was a smaller stroke, and the majority of his neurologic symptoms resolved completely. In the ensuing months that I've had the chance to know him and meet his family, we've been able to show that he's got no inherent blood clotting disorder, which could be a confounding potential alternative reason for a stroke. He does not have that. He also had a loop recorder implanted in his chest. It looks like a paperclip. It's a continuous EKG, and it showed no arrhythmias of the heart.
Now, why is that important? Why is ruling out arrhythmias important?
And it showed no arrhythmias of the heart that could potentially be their own reason for a stroke.
So we have to rule out other causes before we just go and close the PFO.
And so now, through a thorough informed consent with multiple physicians, we're here today very optimistic for a great outcome long term.
So you made the diagnosis using a bubble test, correct?
That's correct.
Dr. Burke, show us what a bubble test is. How is it that we make this diagnosis? What does a bubble test mean?
So a bubble test is where what we're seeing here, and we can see this on the screen, you can inject bubbles into the heart, into the veins, and instead of staying on the right side of the heart, which would be over here, they can cross to the left side, and that's what we're seeing with this. You can see all those bubbles going through. This is the left side of the heart. This is the aorta, the main blood vessel to the body, and you can see how that gets all filled up with these bubbles. That shouldn't happen.
So in other words, that hole in the heart allows for that saline, those bubbles in the saline that we inject through a peripheral vein to actually cross, and that's how we make the diagnosis, correct?
Absolutely.
Okay.
Let me ask a quick question, because the doctor said something that's very important about this case, and that was this wasn't passed down through family members. This is something that he was born with. It just did not close, correct?
Very arbitrary. We don't think this is a genetic predisposition, not this specific type of hole in the heart. And Dr. Shaw and I were talking before we went live. We all remember some fellow student of ours in grade school or whatnot, who had to take time off from school because that young man or young woman was diagnosed with a hole in the heart. So they went to some large referral center, some university center, and they had open heart surgery to close that hole. And now what we're going to do, we're going to get to the case now. We're going to close this non-surgically, without opening the chest as we did 2 or 3 decades ago, with just this catheter-based technique.
Wow, it's so amazing. Now, let me ask you this, Dr. Shaw. Does the heart know that there's something in there? Because that's kind of interesting where, we all have feelings of different things, but does our heart know that there's a piece of a new piece in them?
A piece of hardware.
Yeah, absolutely. The heart's very sensitive to everything, and that's why Dr. Rizik highlighted all the equipment that's here. We're watching the EKG, we're watching the pictures, we're watching everything just to make sure that the heart's not getting irritated. And the heart oftentimes wants to form a blood clot or have an abnormal heart rhythm that results because of having this irritation in the body. But fortunately, with the newer generation devices, that irritation is a lot less, and the risk of having an abnormal heart rhythm that results from something like this is now minimal. So it's great because it truly is non-invasive and less risky overall.
I think that's the important thing, is that these devices have gotten so slick. And this is the Abbott Vascular Amplatzer Septal Occluder. And this device has gotten so slick. When you compare it to the older devices, this is just really a very, very easy deployment. It usually takes about 10 or 15 minutes.
Yeah, and that's one thing we want people to understand at home, is that we're taking you through this, but really the surgery is pretty quick to be done, you can say. I mean, it's very important, but it is, again, where it's not the open heart being here for hours on hours of doing this.
Okay, so you got to close one on the model, the acrylic model, the other day in the office. Dr. Shaw and I are going to close one now, okay?
All right, let's go through it.
All right, so Dr. Burke is going to give me all kinds of really nice echo images, and we're going to do this using X-ray and using the ultrasound. So I'm going to, Dr. Burke is going to guide me. Dr. Burke, is my catheter in a good position to deploy the smaller left atrial side?
Right now we're in a great position. The catheter, you can see right here, the tip is in the middle of the left atrium, and it's nice and free. There's nothing else around it, so there's no issue with anything getting in the way.
So now what I've just done, if you can see on X-ray, and I'm going to, if you can mag up the X-ray.
And it's important to highlight that Dr. Rizik passed through that small hole with just with the aid of Dr. Burke's imaging and the X-ray imaging, because it's a minuscule hole sometimes.
So Dr. Burke, put your cursor, if you would, on, there you go, beautiful. That's the disc on the left atrial side. So we have formed the left atrial disc. Now what I'm going to do, actually what Dr. Shaw is going to do, is he's going to start pulling the device back toward the hole, slowly toward the septum. Let me get on fluoro here so we can see it.
I'm going to pull it back.
No, don't pull it. There you go. All right, come back with the whole thing. Dr. Burke, tell me when we're up against the septum. It looks like we are.
We're up against the septum. That's looking very good. You can see this disc is nice and flush.
All right, now I'm going to form the right atrial side. Now, Dr. Burke is showing off a little bit. He does the best imaging of anyone in the country. He really gives me just such a beautiful target. So now I'm going to deploy the right atrial side, and there we go. So now the right atrial side is formed. Now I'm going to give another, there we go.
And it looks like that clamshell that you were describing with 2 discs on each side of that hole.
So the top disc, the smaller of the two, is what we call the left atrial side. It's on the left side, if you will, of the hole. The bigger disc is on the right side of the hole. So they are going to purse string together on the hole to make sure that nothing can get across, no clots can get across in the future or anything like that.
So why is there 2 different sizes there on 2 different sides?
Because the older devices, the size of each disc was the same, and it used to irritate the heart more. There were some arrhythmias, but by making the left-sided disc smaller, there's fewer complications, fewer arrhythmias, less irritation of the heart. That's a very, very important distinction from what we were doing 10 years ago.
Wow.
Okay. Dr. Burke, why don't you show us some really good ultrasound pictures and convince us that we're in the right place and that now we can let this device go.
Okay, so right now we're seeing the device, and it's actually sandwiching the septum. That's that wall between the 2 chambers. And we've got the left and the right side here, and you can see it right there. Now sometimes you'll do that tug back and forth to
and that's
prove
what I'm
that
going
it's
to do
not
right
gonna go
now.
anywhere.
So I'm going to tug on it first, and it doesn't seem to be going through in one direction. Now I'm going to push on it, and it doesn't seem to be going through on the other direction. So Dr. Burke used the term septum sandwich so that the hole and the wall that the hole is in is sandwiched between the 2 discs. I think this is a really good deployment, and I think it's going to benefit the patient.
It looks good right now on both sides, both on X-ray as well as on the esophageal echocardiogram.
So we use multimodality imaging. We use X-ray. Kind of guides me in a crude way, but Dr. Burke refines the imaging with ultrasound to give me great confidence, to give Dr. Shaw and I great confidence that this is exactly the place to deploy it.
Okay, so now that it's in there, and as you said, it's pulling them together, will the heart eventually close that hole, or is this the piece that will actually keep it closed?
This is going to keep it closed, but then the normal tissue of the heart is going to grow over this, so this becomes somewhat of an afterthought. Normal heart tissue grows over both sides, both discs, and the patient will never know it's there. You can see it on x-ray if he ever gets a chest x-ray or whatnot. He'll be able to see it, but no one will know, he won't know that it's there.
Will he, going forward, have to take any extra medicine or anything that he needs to do, Dr. Shaw?
That's great question. During the procedure, we give blood thinners to form that to make sure that no blood clots form on the device. And then afterwards, for a short period of time, we'll put him on what we call antiplatelet drugs like aspirin and a super aspirin. But after some period of time, oftentimes he can come off of these medications. And so this is a way to actually limit the number of medications needed, as well as reduce the amount of his risk for stroke moving forward.
So our priority now is the patient and getting this done. I think we can let this go, Dr. Burke. Do you agree?
Absolutely.
All
You're
right,
nice
so
and solid.
it is screwed on to this rod here. So we're just going to unscrew it, counterclockwise turn, and there it is. It's a perfect deployment. If you would push the table away from me a little bit, Aaron. There we go, and I'm just going to take a picture so they can see it, a nice clear picture. Beautiful deployment. You can see it's not moving. Now there's still another piece to go. Dr. Burke is going to take some ultrasound images and show us that this is now flush, flat against the septum where the hole is. Dr. Burke?
So again, we're looking at it. You can see how perfectly this sandwiches the septum.
Bob, would you put your cursor on it just to make sure they can see it?
So right here is the device. This is the septum between, and you got the left-sided disc and the right-sided disc. And this holds on perfectly. There was no blood flow through this, so when we throw color on there, there's no evidence of anything leaking from the right side to the left side anymore. And this is about as perfect as you're going to get.
Wow.
Wow. That's amazing to see that. And so let's talk about, as we are finishing up here, because again, going forward, or if someone's watching right now, what should they be looking for, and what type of things can they have done to check and see if they do have a hole?
Well, I think the first thing is it's the bubble study. That bubble study is extremely important. But Dr. Shaw, we don't do bubble studies on everyone, do we?
No, we don't. So it's important to take a step back and just recognize that unfortunately stroke is the 5th leading cause of death in the United States and the #1 cause of disability. And so when people have a stroke, we start investigating why did they have a stroke. We look at their arteries and go into their brain. We look for atrial fibrillation, like Dr. Agarwal highlighted, looking for abnormal heart rhythms. And when we can't find anything else, then we start thinking about, hey, is there a hole in the heart? And unfortunately, people who have a stroke are oftentimes more likely to have a small hole in the heart. And that's where when our antenna goes up to say, hey, maybe we should do a bubble study, or maybe we should look more closely to look for that small hole in the heart. And that's what Dr. Agarwal and Dr. Rizik did in this particular case for this patient.
So think about this. You have an 85-year-old patient who comes in with a stroke, and that's probably not a hole in the heart. If they've had a hole in their heart all these years, it's probably going to show up before they're 85. But in this case, we have a gentleman in his mid-40s, a healthy young man, working out, etc. Now, if your antennas go up, then when you say a young person with a stroke, you better be thinking of a hole in the heart. Or if you have a young woman, say, who's on birth control pills and is smoking, that is almost for certain, if it's a young woman who has a stroke with those risk factors, that's almost for certain going to be a PFO, a hole in the heart. So based on their presentation, their age, their risk factors, etc., you tend to think of this is more likely to be a PFO, this is less likely to be a PFO. Dr. Agarwal very astutely, when he saw this patient for the first time, he said, boy, I'm pretty certain I know what we're dealing with, but he still did the rest of the workup to make certain there were none of these other potential causes. And he ended up, his clinical intuitions were right on the money. He ended up proving that this patient had a PFO with the bubble study showing crossing, but nothing else, no other potential causes, no atrial arrhythmias which can cause a stroke, He looked at the carotid arteries, nothing there. I think it was really, really, really good clinical medicine on his part, the way he made this diagnosis.
Wow, okay. Going forward, what will this patient have to do to stay healthy, especially after a surgery like this?
Well, the first thing, the patient's going to have to take blood thinners for the next 6 months. We want this to heal, so the blood thinners are 2 medications like aspirin and another drug called clopidogrel, and that will allow this to heal. And then Dr. Agrawal, he just has to get healthy. He's on cholesterol-lowering drugs already. He's got a family history of vascular disease.
That's correct. So ongoing counseling and the conversation will evolve as we get to know each other more. But basic lifestyle, choices that are positive rather than negative.
Dr. Shaw,
the point that's to be made is, unfortunately, somebody who's had a stroke is more likely to have more strokes in the future. So you have a 25% risk for having a recurrent stroke once you've had one stroke. And that's why Dr. Agrawal and other doctors are really, really passionate about doing everything they can to preventing a recurrence of strokes. And so that's why we watch your cholesterol, your blood pressure, make sure you're on all the right blood thinners and otherwise.
Okay, say for instance someone right now at home is sitting and thinking about this, but also going, well, I don't know if I want to go on for the surgery. Is there a way that you can monitor this, the way you can take care of yourself before you get to this point, or do you really need to have this surgery done?
Unfortunately, the alternative therapy, there is an alternative therapy. There's actually 2 alternatives. We showed closing it through a catheter-based methodology. Some individuals may choose to have it closed surgically, and sometimes if the hole is too big or the morphology of it is really different, you may have to turn to a surgical closure. The alternative therapy, though, is lifelong blood thinners. The problem with lifelong blood thinners, it doesn't work as well as preventing strokes as this device does. There's a higher rate of recurring strokes with blood thinners, and over your lifetime, the risk of bleeding on blood thinners is about 1 in 3. About 33% of patients who are on chronic blood thinners will have a bleeding episode, as opposed to with this device, you're only on blood thinners for 5 or 6 months.
Yeah, I know we're getting close to finishing this, and I know that you're going to let them finish up. Doc, why don't you and I step over this way as they finish that up, and let's talk a little bit about, of course, heart disease, talk about the different things that you want people to start watching for, especially as we start to get back out and start to meet people and start to see people and stuff and family members.
You and I have spoken over the last year, and you've been such a strong advocate of healthy living, healthy lifestyle. And we can't emphasize enough eating healthy, getting out and exercising. Don't ever pick up a cigarette. If you have diabetes or hypertension, get that treated. But in this particular case, there was nothing this gentleman could have done differently to prevent this. This is something he was born with. It wasn't acquired. This was what we call, as I said earlier, a congenital abnormality. But I think our bottom line on all of heart disease management is see your doctor, establish a healthy lifestyle, healthy living, see your doctor regularly, and that will help you to really, really enjoy your life.
So, and we also have to say that your team works so well together of knowing the different areas to come together to take care of people, and that's, again, we want to emphasize that with these procedures, that it's just not Dr. Rizik, it's a team.
No, it starts off in the office with general medical counseling, as Dr. Agrawal spoke about, and then the high-end imaging and diagnostics that we do, and then eventually, if a patient does make it to the cardiac catheterization laboratory, it's having great team members like Brittany, Aaron, and Megan who know the movements in here, who anticipate our movements in here, and really understand what we need to do during this procedure to make it successful.
Well, I'll tell you another successful procedure that I've been a part of, and that you, the viewers, have had an opportunity to watch. We do ask you to go to aztv.com/theprocedure to learn more about all that we've done here. So, Dr. Rizik, thank you, and thank you to your team.
It has been great to have Brad Perry back with us.